so that we will still have recording, I hope. Okay. I don't know if they've changed the... Let me log out and log right back in. Okay, Brittany doesn't hear me. Does anybody else hear me? Yes? Okay, Brittany, it must be a problem with your computer. Okay, I'm going to log out real quick and log back in to see if I can get the camera to come up. Just hang in there. You shouldn't get kicked out or anything. Okay. Okay, can you hear me? Okay. Okay, it's being recorded. Hang on, I'm going to turn those overhead lights off. It's glaring. Okay, I wasn't, okay, Brittany can see but can't hear. Can everybody else hear me? Okay, Brittany, you might need to, well, let me type it to her. Okay. Okay, so we're recording and, okay, thank you, Sherry. That's what I told her to log out and log back in. Okay, tonight we're going to talk about endocrine disorders, specifically like thyroid and adrenal, not diabetes. And next week we'll do some diabetes case studies. I know that diabetes is there's a lot of material, and it's pretty complex, so I wanted to give you an extra week to read that material before we do the case study, because I'd like for you to be able to actually engage and answer some of the questions as we go through that, rather than just kind of a straight lecture. This one tonight is more just of a straight lecture, so you just kind of sit back and listen, but and obviously ask any questions. But next week I'd like it to be more interactive and a case study. So is everybody doing okay with the diabetes content? A lot of it. It is a lot of information, and it is very complicated. This is probably, well, hypertension, was complicated too, but now instead of, like in the fall, we kind of looked at systems and you looked at one illness at a time, pharyngitis, sinusitis, pneumonia, things like that. Now we're looking at long-term chronic illnesses that affect the whole body. So, hypertension affects the heart, the blood vessels, the eyes, the kidneys. Diabetes is the same way. It affects every system in the body. So are these endocrine and thyroid disorders. So it is a big jump, from having to just learn about, how to treat one acute illness to having to treat chronic illness. And this is what you're going to be doing all summer, and I'm sure you're doing a lot of this in your family practice clinical too, seeing older patients that have multiple comorbidities and that have chronic illnesses. The medications and everything on diabetes, the biggest thing that will help you, I think, is to try to fill out that chart, the blank chart that I put in there. I at least for me, I find reading the information and writing it down does help me to retain it, and I think that's kind of a proven memory aid for most people, and learn it by class. You don't have to know the name of, the exact name of every GLP-1 if you know that they all end in tide, the extendotide, all the other ones, they all end in TIDE. So you look for the tides. And you learn the actions and side effects and contraindications by class. And that helps a whole lot more, to keep you from being quite so overwhelmed. So Lydia says it's the medications and treatments. And we're going to, the big blue button next week will be long. I'll just warn you, because it is we're going to go through one case of a man that I saw at the health department several years ago, and I saw him for about 3 years that I worked there. So I kind of followed the progression of his disease. And it is very complicated, and there's a lot of factors to, diabetes isn't one of the, neither is hypertension, where you just say you have this, you're going to get Augmentin. There's a lot of choices. There's a lot of classes of medications. And diabetes especially, there are a lot of different things to consider before picking which one. There's not an algorithm that says, everybody gets this, except pretty much metformin. Everybody starts with that. But from there on, it's a lot of different factors that go into the decision-making of what your patient will get. So we'll go over that, but I wanted to give you an extra week to try to get through, your textbook readings and the ADA guidelines. And Melanie says insurance hoops too. Yes, there's a lot of really expensive medications. I was watching your forum as you were talking about the, I guess it was probably the Repatha and the whole issue with trying to get insurance to cover things like that. And there are a lot of new diabetes medicines that are also very expensive, the SGLT1 or SGLT2 antagonists. But tonight we're just going to talk about endocrine disorders. These are a little more common. You're going to see a lot of thyroid disorders in family practice and in internal medicine. So let's go over those. First, let's just look a little bit at review of your pathophysiology in case you've forgotten this. If you start getting confused, go back to your pathophysiology book and look at it. And remember that, you've got that pituitary, hypothalamus, thyroid loop that involves a lot of different hormones and releasing factors and things like that. And it's usually a feedback loop. So we'll start here. You have homeostasis, which means, everything is fine. You have a normal T3 and T4, which are the active thyroid hormones. You have a normal body temperature. Everything's going along fine. Then something happens to cause your homeostasis to be disrupted. Either you have a decrease or increase in your, this one's talking about decrease in your thyroid hormone, T3 or T4, or low body temperature. That stimulates the hypothalamus to release thyroid releasing hormone. That goes to the anterior pituitary, and then the anterior pituitary releases thyroid stimulating hormone, or TSH. You'll see a lot of that. That's what we actually measure to look at thyroid problems. The TSH goes to the thyroid gland to stimulate the release of T3 and T4 from the thyroid follicles. That's the active thyroid hormone. The T3 and T4 increases in concentration in the blood, and you're back to homeostasis. So, this is a feedback loop. So this is what occurs naturally, but then if you have a problem and you have to replace thyroid hormone with like Synthroid, same thing is going to happen. Instead of the thyroid releasing extra thyroid hormone, you're supplementing it. So, it still has that feedback loop. Okay, so some tests that you would do to check out the thyroid function. TSH is the ultrasensitive assay, and that's the most sensitive test to use to screen for either hypo or hyperthyroidism. That's the one you're going to do in internal medicine. You'll do it all the time. The normal range is 0.4 to 4.0 milli international units per liter. And you might find different reference ranges if you look in one of your lab books or different textbooks. I'm not sure what Smith says. I'm pretty sure that McPhee is the 0.4 to 4.0. But for this exam, I want you to know the 0.4 to 4.0. So, consider this the normal range for this exam. Don't come back and say, well, I found it in this other book, that it said 4.2 or something like that. But this is what we're going to use just to avoid any confusion. However, over 95% of normal adults will have a TSH of less than 3. So by the time it's up to 4, you're kind of getting a little suspicious that things aren't working quite so well. TSH is greater than 4 with a normal free T4, which is the active thyroid hormone, is how we diagnose subclinical hypothyroidism. It's usually asymptomatic, but you would want to monitor them closely for the development of hypothyroidism. This means that the thyroid is not putting out enough thyroid hormone, and the anterior pituitary is having to, secrete more and more TSH to get it, say, come on, wake up, thyroid, put out some hormone for me. So you want to watch them. TSH is elevated in hypothyroidism because remember, you're not secreting enough thyroid hormones, so you're hypothyroid. Your anterior pituitary is saying, wake up, thyroid, here's some thyroid stimulating hormone, get you going. And then if your thyroid is producing too much thyroid hormone, your TSH is going to be decreased because that negative feedback, your pituitary says, whoa, we've got way more thyroid hormone than we need. Stop, shut off the TSH. Do we prescribe Synthroid if TSH is elevated above 4? If you diagnose them with hypothyroid, yes, and we're going to go through that a little bit more. Okay, so free T4 is free or unbound thyroxine, which is a metabolically active form of T4, and free T4 will be increased in hyperthyroidism, too much thyroid hormone circulating, and it will be decreased in hypothyroidism. And the lab values for that, I'm not going to ask the lab values on that for the test. I might say it's increased or normal or decreased, but the lab values vary depending on what technique is used and what everybody's lab has different reference ranges. So I'm not going to ask you to memorize that. T3 measures the metabolically active form of thyroid hormone triiodothyronine. I never can pronounce it. And that one, again, will be elevated in hyperthyroidism, too much thyroid hormone circulating. And it's only indicated when you suspect hyperthyroidism, but the T4 is normal. So you've done a TSH and it's low, you're thinking that they have hyperthyroidism, you do a T4 and it's normal, then you can do a T3 to see if it's elevated. It's not useful in the diagnosis of hypothyroidism, so you would only use it for hyperthyroidism. And then antibody titers. You can develop antibodies to your thyroid, and the antibodies will attack the follicles and cause either hyper or hypothyroidism. And there are several different ones: anti-thyroglobulin antibody, anti-thyroperoxidase antibody, thyroid stimulating immunoglobulin, TSH receptor antibody, and all of these are usually positive or elevated in Graves' disease. So first let's talk, can we do labs all at once? Now, the first thing you do if you're suspecting a thyroid problem is a TSH, and you go from there. So, because the workup's going to be different, so you want to know, is it elevated or is it low? So first you would do a TSH to find out. Then you would do the T3 or T4 as indicated, depending on whether it's, you're thinking hyper or hypo. So hypothyroidism is very common. It affects about 1% of the population and about 5% of the population after the age of 60. It affects, remember your thyroid gland is kind of the regulator of your metabolism. So it's, the function of your thyroid is going to affect almost every system in the body. So symptoms can be very mild or even asymptomatic to very severe. Hypothyroid is usually due to failure or destruction of the thyroid gland. And in the United States, the most common cause is Hashimoto's or autoimmune thyroiditis. And we're going to talk about that in a little bit. It can occur due to severe non-thyroid illness, like just severe illness. You're in ICU. A lot of times your TSH will go up, indicating that you're hypothyroid. And this is called euthyroid sick syndrome. And it affects females 5 to 8 times more than males, especially after the age of 40. So it's very common in middle-aged and older women. Some of the clinical manifestations, again, it can be very mild or asymptomatic, and they can be very vague symptoms. When I read these, there's a constellation of symptoms, and a lot of these are very vague, like fatigue. Everybody has fatigue, and fatigue can be so many different things. So some of the common symptoms, remember the thyroid gland is in charge of your metabolism. So if your thyroid is not working correctly, you don't have enough thyroid hormone, everything's going to slow down. So you get weight gain. You're not burning calories as much. Your metabolism isn't as active. You're going to get lethargy, depression, weakness of the muscles, dyspnea on exertion, arthralgias, muscle cramps, heavy periods or menorrhagia, constipation. The GI tract slows down, dry skin, headache, paresthesias, cold intolerance, and Raynaud's syndrome, which is the vasospasm of the fingertips in the cold. Some of the common physical findings include bradycardia, so everything is slowed down, diastolic hypertension, again that dry skin with brittle nails, coarse thinning hair. They'll have peripheral edema, like in the ankles and the pretibial edema, a puffy face and eyelids. Their skin is usually pale and dry, and their DTRs will be hyporeflexive. Everything is slowed down. They may have a goiter or enlarged thyroid gland, especially if they have thyroiditis, which is inflammation of the thyroid gland. The labs for hypothyroidism, TSH again is going to be the best screening test to check for hypothyroidism. And after the age of 40, that's kind of one of the, if you go to the internist, that's just like A1C and CBC and CMP, that's going to be one of the screening labs you're going to get every couple of years. TSH will be elevated in primary hypothyroidism. The free T4 is usually maybe low or low normal, and antibodies will be positive if you have autoimmune thyroiditis like Hashimoto's. And many factors, especially drugs, can result in abnormal lab tests, and there's a list of those in NICB on table 26.4. And you want to do a CBC to check for anemia because, the fatigue and everything else, you want to make sure that that's not it, and a lipid panel to check for hyperlipidemia. Let's see, Stephanie says the doctor she's precepting for uses TSH range of less than 2 and free T3 range of 3.5 to 4.2. Any TSH over 2 with a low free T3, he diagnoses hypothyroidism with a low dose of Synthroid. Just wanted to see what you thought of this and what you would recommend. We're going to talk about subclinical hypothyroidism, which technically is a T4 of greater than, a TSH of greater than 4.0, so like 4.5 with a normal or free T4. And those patients may have symptoms of hypothyroidism, but like I said, 90% of normal adults have a TSH of less than 3. So by the time you get above 3, you're kind of thinking that the thyroid isn't working so well. Different physicians choose to treat it differently, especially if the patient is symptomatic. Remember, treat the patient, not the labs. So, he may be treating them for subclinical hypothyroidism. And if they're having symptoms, then low doses of Synthroid may help them. And we'll talk about that a little bit more in a minute. So before beginning thyroid hormone replacement, you want to look both for adrenal insufficiency, and we're going to talk about that in a later section, and you want to ask about any history of angina. Why would you want to ask about angina before giving them thyroxine? What's thyroxine going to do to their cardiovascular system? She says arrhythmia, increase their heart rate, maybe increase their blood pressure. Remember, this is the thyroid hormone is the driver of your metabolism. And right now your metabolism is slow and sluggish. So you're going to give them, synthetic thyroid hormone to rev it up. And if you have angina due to cardiovascular disease, then increasing the demand on your heart may cause an exacerbation or heart attack. So you always want to look at that first. And if they do have angina, then you want to have them evaluated by a cardiologist before you start them on any thyroid replacement. Okay. So first line treatment for hypothyroidism is going to be thyroid replacement, which is usually levothyroxine or Synthroid. The initial dose is usually about 25 to 50 micrograms per day, and the usual therapeutic dose is 75 to 125 micrograms a day. You want to adjust the dose by about 25 micrograms every 1 to 3 weeks until the patient is euthyroid or has a thyroid hormone in the TSH level between 0.4 and 2.0. So when we're treating hypothyroidism, we don't want it just to get to 4. We want it to stay down here, 0.4 to 2.0. Okay, because just like I said, 90% of people have a thyroid TSH under 3.0. So you wouldn't just treat it. If you started out with a TSH of 5.2, you wouldn't just treat it until you got to 4. You would want to go down to 2. Okay, so that might be why Stephanie's preceptor is a little more aggressive with his treatment. With elderly patients, you want to start low and go slow. You don't want to increase their levothyroxine too rapidly. It requires much lower dose than it does in younger adults, and pregnant patients require higher doses. And this is one of those drugs that brand does matter. A lot of things, generics are fine, and there's really not much difference between name brand and generic drugs, but there is a big difference in bioavailability with the different brands of levothyroxine. So it's important to know, either go ahead and, if the patient can afford it and has insurance, go ahead and prescribe Synthroid, the brand name, or at least tell them to get their thyroid hormone filled at the same pharmacy every time. Hopefully that will be the same from the same company. But what happens is, big pharmacies like Walmart or Walgreens or anything, they'll buy their drugs from different manufacturers based on price. So if, company A has the best price for 2017, they buy it from them, and then in 2018, maybe company B has a better price on levothyroxine, so they change. So if things start, you have a patient on a stable dose, and all of a sudden they start having symptoms or their TSH starts going up, ask them if their pill looks different, whether they have a different color pill or a different size or different thing that might mean that they have a different brand, and you need to check their TSH. Why is it so much of an issue with thyroid meds that you don't hear about it with other drugs? It's just a matter of the bioavailability. Thyroid is so picky. Little tiny changes in your thyroid, in your levothyroxine dose can make your thyroid, your TSH swing greatly. And things like antibiotics, for some reason, there's just not that much difference in the bioavailability. The amount of the medication in that pill that actually is active is about the same with name brands and generics, but with thyroid medications, it's not. So it's just one of those things to be aware of. There are many interactions with food and drugs, so thyroid hormone should always be taken on an empty stomach first thing in the morning. And when I was talking about the different brands and everything, well, I'll tell you when I get to this. You want to recheck their TSH 4 to 6 weeks after changing the dose or after changing a brand. So if they've gone to a new pharmacy or they said, now, my pill used to be white, now it's pink, go ahead and check their TSH and make sure that it's still within range. And it takes a few weeks for them to get a steady state on one dose, so you don't want to change too frequently. Thyroid replacement therapy is generally going to be needed for life because most of this hypothyroidism is due to autoimmune destruction of the thyroid gland. And you always want to inquire about patient compliance before making any dosage adjustments. A high TSH may mean that they're just not taking their medicine. So, you always, just like we talked about with asthma, if they're out of control, first check compliance. So ask them, are you taking your medicine every day? One more not kind way, but accepting way is to say, we all forget medicines every now and then. How often do you forget to take your medication? That kind of gives them permission to say, well, 2 or 3 days a week, I usually forget. So you want to ask about their compliance. Maybe they have lost insurance, or maybe they're in the donut hole and they're having to pay a lot of money for their medications, and they just haven't been buying it. I had a patient at the health department a few years ago, and she would come in and I'd do her TSH, and it would be either real high or real low, and I would adjust her levothyroxine, and then 4 weeks later I'd check her TSH, and it would just it was just going up and down and up and down and bouncing around. And I was like, I'd call her and say, okay, now let's do this. Now let's do that. And finally, I said, and she said she was taking her medicine. And I finally said, okay, get your medicine out, in your hand, or get the bottle and read it to me. Tell me what you're taking, what dose, because we had changed the dose several times. And she said, I'm taking, 37.5 micrograms or whatever it was. And then she said, oh my goodness, there's 2 different color pills. Why would they give me 2 different color pills? I don't think they did, but she was convinced that the pharmacy had given her 2 different medications. And I think what happened is when we changed her medication, it was probably in the middle of a prescription when she still had some left. She got the new prescription, dumped it in the old bottle with the old prescription. And so she was just taking whatever happened to fall out in her hand that morning. She didn't even notice that they were 2 different colors. So her TSH was just bouncing all over the place because we didn't know what she was taking. So you always have to, check those things out before you go too crazy. Let me see what these questions are. Melanie says that McPhee mentions the medication of levothyroxine and triiodone. When do you use that one? And does the natural porcine medicine work better or worse? The natural one is that Armour thyroid. Some people swear by it. I think it's just a matter of preference. If you can't get them regulated on Synthroid or levothyroxine, then you can try the Armour thyroid. And the other one, if you give me a page, I'll go look it up. With levothyroxine plus triiodine, I'm not sure about that one. So if you put a question in the forum with that, I'll look it up and give you an answer to that. Ashley says her mother's endocrinologist said the natural choices like Armour thyroid don't work well at all, and she doesn't use them at all. I've never prescribed it. I've always used levothyroxine or Synthroid, but some people swear by it. So, it's just a matter of preceptor preference and patient preference. I think it's more expensive, so that might come into play. You want to use the lowest dose of levothyroxine that results in a euthyroid state or normal TSH. And remember, for treatment, we're saying to try to get them down to TSH of less than 2. You want to use caution, again, in patients with cardiovascular disease, coronary artery disease, and inquire about angina and get a cardiac consult prior to treatment if they do have angina. And you want to closely monitor the TSH in pregnant patients because the dose needs to be increased as the pregnancy progresses. They have higher metabolic needs, and so their dose of thyroxine is going to need to be increased. Okay, any questions on hypothyroidism before we move on? Okay, so next we're going to talk about hyperthyroidism or thyroid toxicosis. The overall incidence is about 1.3%, and like most things, increases with age. Again, more common in women, 5 to 8 times more common than in men. And the most common causes are Graves' disease, toxic multinodular goiter, thyroiditis, or excessive doses of thyroid replacement hormone. So, you can put somebody into hyperthyroidism by giving them too much levothyroxine. So Graves' disease is most common in young women and women in their 20s to 40s. It's an autoimmune disease with a genetic component. There's an increased incidence of this in patients with Down syndrome, smokers, patients that have other autoimmune disorders like type 1 diabetes, rheumatoid arthritis, pernicious anemia, Sjögren's syndrome, lupus, anything that is autoimmune. You want to check their TSH at regular intervals to see if they're developing Graves' disease. It can be triggered by excessive iodine intake in the diet or in drugs like radioiodine contrast or the antiarrhythmic drug amiodarone. Some of the types, the toxic multinodular goiter is most commonly seen in elderly women. Toxic adenoma is just a single adenoma on the thyroid, and it's called Plummer's disease. Thyroiditis is commonly transient, and you get transient hyperthyroidism, and then the thyroid cells get destroyed, and it's followed by hypothyroidism. Subacute or sequelae thyroiditis can be due to a viral infection, so sometimes it causes a transient hyperthyroidism, and then they go back to normal. And then Hashimoto's thyroiditis, this is the most common cause in the U.S., is damage to the thyroid gland that results in release of excessive thyroid hormone during the destructive phase. And this occurs in 5 to 10% of women during the postpartum period. They'll develop this right after pregnancy. Sometimes they go back to a normal thyroid. Sometimes it destroys too much of the thyroid, and they become hypothyroid after that. So clinical manifestations, kind of the opposite. Remember, the thyroid hormone is controlling your metabolism, so you have too much thyroid hormone, and your metabolism is in overdrive. So instead of weight gain that you had in hypo, you have weight loss. Everything is in overdrive. You have palpitations, atrial fib, nervousness, irritability, heat intolerance, where you had cold intolerance with hypo. Now you can't tolerate heat. Smooth, warm, moist skin, thin, brittle nails, fine hair, fatigue and muscle weakness, decreased menses or amenorrhea, frequent loose stools, dyspnea with exertion, and sweating. So everything is in hyper overdrive. Some of the physical findings: atrial fibrillation, a prominent stare. They have exalgamos, where their eyes appear to bulge. That's kind of a late symptom. Lid lag, hyperreflexia, fine tremor in their hands, and fever. Even their body temperature is elevated. The thyroid can be diffusely enlarged if it's something like Graves' disease. It could have nodules if you have like multinodular goiter, or it could be tender if they have thyroiditis, which is due to like a viral infection or something. Then it might be warm and tender. The labs you would want to do in hyperthyroidism, again, a TSH to screen, and it will be decreased because the anterior pituitary is saying, okay, we've got too much, shut it off. Your free T4, which is that circulating, will be increased, as will the T3. Those are both the active thyroid hormones. Thyroid resin uptake will be increased. TSH receptor antibodies are detectable in about 65% of patients that have Graves' disease. Anti-thyroid antibodies are usually increased, and a radioactive iodine scan and uptake is usually high. They'll do that, inject some radioactive iodine, do a scan of the thyroid, and you see the uptake is a lot. It's going right to the thyroid. And thyroid ultrasound is usually done to evaluate nodules, if you feel nodules there. Treatment, the first treatment is just with propranolol, extended release, and this is for symptomatic relief. It's not going to do anything for the thyroid, but it will help with the symptoms. And you can give that, if you think it's transient, like Hashimoto's, or you think due to a viral illness, then you may just be able to give them propranolol for symptomatic relief until it resolves. You start with 60 milligrams once or twice a day and increase as needed to a maximum of 320 milligrams a day, and then reduce the dose as symptoms resolve and their free T4 normalizes. So this will help. Propranolol is a beta blocker, so that's going to help with AFib or with the palpitations. It'll help with their blood pressure. What if the patient has low blood pressure? Usually they don't have low blood pressure when they have hyperthyroidism. Everything is usually elevated. So that's not usually going to be a problem. So the propranolol is really just for symptomatic treatment. To treat the actual thyroid gland itself, to stop it from producing so much, you can use either methimazole, which is tapazole, and that's 30 to 60 milligrams a day. And this is preferred if the patient is going to get radioactive iodine treatment. You discontinue it about 4 days prior to the treatment. It has been associated with birth defects, so you don't use this in pregnancy. And then there's propylthiouracil, or PTU, and this is the drug that's favored in pregnancy or in breastfeeding. Remember, hyperthyroidism is very common right after pregnancy, so they may be breastfeeding. So because this one, it crosses both the placental barrier and is excreted in the breast milk, you don't want to give tapazole if they're breastfeeding or pregnant. For PTU, the initial dose is 300 to 600 milligrams a day, divided QID, and again, reduce the dose as the symptoms resolve and free T4 returns to normal. Radioactive iodine, or I-131, is used to destroy overactive thyroid tissue. There aren't any risk of later malignancy, from the short period of time that they're radioactive or exposure. It is obviously going to be contraindicated in pregnancy, because you wouldn't want to give anything radioactive while you're pregnant. You discontinue the tapazole 4 days prior to the treatment. The free T4 levels fluctuate for the first few months and then fall to hypothyroid levels. And then many patients will develop hypothyroidism requiring thyroid hormone replacement, which would be for life. So you want to continue to carefully monitor them. It's hard to, give this drug and not destroy most of the thyroid glands. So, most of them are going to develop clinical hypothyroidism after treatment. And then surgery is not used as much anymore because of the radioactive iodine is non-invasive, but it is definitive treatment if they have multinodular goiter or if you suspect a malignancy, and can be used in pregnant women that can't be controlled with PTU because you can't give them radioactive iodine. Okay. So any questions about hyperthyroidism? Shannon, are we checking the TSH free T3 and 4 labs while the patient is fasting? Does diet affect the results? I do not believe that they have to be fasting. I can look that up, but I don't think that they have to be fasting. It's not like lipids or anything, because you're not given the, thyroid replacement hormone. The levothyroxine is affected by food, so you don't want to take it while you're eating. You want to take it on an empty stomach. But I don't think that the TSH and everything in hyperthyroidism is going to matter if you're fasting or not. And Melanie asks for the thiourea drugs. McPhee seems contradictory with itself about pregnancy and breastfeeding. Go with the PowerPoint. I know that we talked about this a little bit in the last unit of 568 when we talked about hyperthyroidism in pregnancy. But most of the time, there are some instances where you can use PTU later in pregnancy, but it does have risk of fetal malformation, so you definitely don't want to use it Tapazole in early pregnancy. So you definitely don't want to use this in early pregnancy. You want to use PTU. But for this, know that you use PTU for pregnancy and breastfeeding, Tapazole for other people. But if you put this in the forum, because I won't be able to see this, you put this message in the forum, I'll look it up and see what the conflict is in McPhee. Okay, so some other other endocrine disorders. Cushing syndrome is hypercorticosteroid. I can't talk today. I'm really tired. I've been DIYing and refinishing furniture today, and the first 2 or 3 hours of that is fine. The last few hours, not so much fun anymore. So hypercortisolism, so too much cortisol, refers to manifestations from overexposure of the tissue to corticosteroids, and it's most commonly due to excessive doses of corticosteroids that are being given by providers. So it can also be due to ACTH hypersecretion from a benign pituitary adenoma or from a non-pituitary neoplasm, usually lung cancer. It also can be caused by an adrenal tumor, which secretes excessive amounts of cortisol independent of ACTH. So, but the most common cause is going to be excessive use of corticosteroids. Some of the signs and symptoms: central obesity, which is where you get that apple shape. You have a protuberant abdomen and thin arms and legs. You get a cervical fat pad. I don't know if you've seen this, called a buffalo hump. It right at the top of their back and the bottom of their neck, they have a big pad of fat. Makes them look like they have kyphosis because they have this big lump there, but it's actually fat. They'll get edema of their face and kind of the swelling called moon face. You might see people that are undergoing treatment for cancer that are taking high doses of corticosteroids, and they get the round face. Oligomenorrhea, which is loss of your period, or oligomenorrhea is just very slight periods, or amenorrhea, loss of your period, erectile dysfunction, acne and superficial skin infections, muscle weakness, hypertension, osteoporosis and avascular bone necrosis. You'll have purple striae, usually on the abdomen. They've got that big fat belly, and they have purple striae on their skin, easy bruising. Symptoms of diabetes: polyuria, polydipsia, and elevated blood glucose. We always talk about diabetics and be careful giving them steroids. If they have a infection or something, and you're going to, asthma exacerbation or some kind of infection that you want to give some steroids for, you need to be careful because steroids increase your glucose, and you'll have symptoms of diabetes. Glaucoma is worse, and mood swings and psychosis can be symptoms. Some of the lab findings are impaired glucose tolerance and elevated blood glucose and glucosuria, decreased bone density. Remember this, we talked about the importance of taking calcium and vitamin D if you're on long-term corticosteroids, because it does cause osteoporosis. So you'll see this on DEXA scan. Can cause lower levels of potassium, so you get hypokalemia, elevated cortisol levels, and because this is hypercortisolism. So you can measure that either with a 24-hour urine-free cortisol, serum cortisol, or the salivary cortisol levels. Serum ACTH levels will be low if they have an adrenal tumor, and high if they have a pituitary tumor or an ectopic ACTH secreting tumor. And the diagnostic test for this is the dexamethasone suppression test. Treatment of Cushing's due to a tumor is going to be surgery, surgical resection of the tumor. Treatment of Cushing's due to excessive corticosteroid dose is, the biggest thing is prevention. Limit long-term high-dose corticosteroids if you can. Obviously, if it's somebody that is undergoing treatment for leukemia or something, you can't always do that because they're using those to suppress the immune system. But a lot of patients get high-dose steroids for musculoskeletal problems. They have rheumatoid arthritis or other problems that are causing inflammation, and steroids are potent anti-inflammatories, so they've been on steroids for a long time. Most patients on daily steroids for over 2 to 4 weeks will have some degree of hypothalamic pituitary adrenal suppression because, again, it's a feedback system, and you're supplying corticosteroids, so it shuts down the hypothalamic axis, and you stop producing your own. You want to taper a corticosteroid dose as appropriate for the underlying disease. So if they've been on something for a long time, you don't want to stop because their body has stopped producing cortisol on its own. And if you stop giving them oral corticosteroids, suddenly that put them into crisis. So taper. Usually, if you have 5 to 7 days of corticosteroids, you don't need to taper. You will see Medrol dose pack, that's a typical taper. That's only a 5-day treatment. You're not going to get Cushing syndrome from taking 5 days of steroids. So it's usually much longer, 2 to 4 weeks. Again, calcium and vitamin D supplements to help prevent osteoporosis, and alcohol detoxification if they're alcoholic. When reading through treatment for Graves, ophthalmopathy, and weeks of prednisone, I was thinking, couldn't that trigger Cushing's? I'm not sure what you're asking. That treatment for Graves is prednisone? I guess it would depend on how many weeks you give it and at what dose. So obviously, there are a lot of illnesses that you're going to have to, so 6 weeks of IV, you're going to have to, you won't get Cushing's if you taper it. So you need to, as long as you're giving them prednisone, they're not going to have it because they've got enough steroid on board. You're giving it to them. It's when you stop it suddenly that they can get it. So that's why you would want to limit, the dose as much as you can. Only use it for the amount of time that you absolutely need to, and then taper it so that their body starts making their own, because you've suppressed their pituitary glands. So you need to, taper the dose so that it slowly comes back, instead of just, don't give them high doses for 6 weeks and then just cut them off. It's kind of like an alcoholic going into TTs. So that's it on Cushing's. So the main thing on Cushing's is it's either going to be due to a tumor and treatment has going to be surgery, or it's due to excessive doses of corticosteroids, and you do what you can to prevent it by limiting high-dose, long-term corticosteroids. If they do have to have those, then you taper the dose as soon as you can to allow their body to start making their own again. Okay. Addison's disease is the last thing we're going to talk about, and this is chronic adrenocortical insufficiency. 80% of the cases are caused by autoimmune destruction of the adrenal glands, and tuberculosis is a leading cause in countries where TB is prevalent, like India and some of the third world countries. There are several rare genetic disorders that result in adrenal hypoplasia and insufficiency, so that they're born with it, and you'll see that in children sometime. That's not something you would be managing. They would be with a pediatric endocrinologist. And then secondary adrenal insufficiency can occur after abrupt discontinuation of corticosteroids. Same thing I was just talking about. You've basically shut down the whole pituitary, hypothalamus pituitary adrenal axis, that whole feedback system, by giving them exogenous corticosteroids. So you need to taper it so that the body can start making its own again. So to prevent that, you would taper the corticosteroids. Some of the symptoms of Addison's are weakness and fatigability, anorexia and weight loss, nausea and vomiting, diarrhea, muscle and joint pain, amenorrhea, increased skin pigmentation, sparse axillary hair, and hypotension in the small heart. Lab findings, they'll have a low serum sodium, elevated potassium, calcium, and BUN, anemia with eosinophilia, neutropenia, and lymphocytosis. The plasma cortisol levels are going to be low, and they will fail to raise after administration of corticotropin, which is what stimulates you to release cortisol, and they'll have an elevated serum ACTH level. Treatment is replacement of corticosteroids and mineral corticoids. Hydrocortisone is going to be the drug of choice, 15 to 30 milligrams in divided dose. This is probably going to be lifelong because that destruction of the adrenal glands. So you're replacing the normal cortisol that they can't make on their own. Alternative is prednisone, 4 to 6 milligrams in divided dose, and the doses need to be increased if there's anything that increases metabolic stress, like surgery, infection, trauma, or any other kind of stressful events. Your body, cortisol is your stress hormone, so you need more of that when your body's under stress. So if they have any stressful events, you have to increase their dose of corticosteroids. And fluorocortisone acetate is sometimes needed to treat hyponatremia. It's also used to treat hypotension, postural hypotension that these patients get. You want to treat them vigorously and avoid infections, and they should always wear a medic alert bracelet, okay? Because they can, if their cortisol levels drop too low, they can go into a coma. So if the patient is diagnosed with Cushing's and the tumor is removed, then they will have Addison's. No, not necessarily, because in Cushing's, let's go back. Cushing's, you have too much cortisol, too much corticosteroids. So it could be from two things: either a tumor that's secreting too much, you have an adenoma somewhere that's secreting too much. If you remove that tumor, then you should go back to normal. Or you're giving them too much exogenously. So they hopefully would just go back to a normal state if you remove the tumor. And because it's usually a pituitary adenoma, so you're not going to remove the whole pituitary gland. It's just a little benign adenoma, and you can take part of that. So hopefully they still can secrete enough of their own. So hopefully they don't go into Addison's after that. Let's see. So if you treat Cushing's syndrome caused by excessive doses of corticosteroids, you would just give more steroid and taper off slowly so the body makes its own steroids. Okay, Cushing syndrome, you have too much steroid on board, so you're just going to taper their steroids. You can prevent it by not putting them on high doses for a long time, if possible. I mean, if it's, like I said, if they have leukemia or something, you might have to, but that's usually going to be for a definite period of time, and then you taper them off of it. But some people, I think it's probably not quite as common now because we have so many more medicines for inflammation, like people that have rheumatoid arthritis and things. We have biologics now, Humira and things like that. So it used to be that when we didn't have those, you put them on high dose corticosteroids for the inflammation, because that's what rheumatoid arthritis is, inflammation, for forever. So they would frequently get Cushing's syndrome. So Cushing's is too much cortisone. So it's either due to an adenoma that's secreting too much, or excessive use of corticosteroids in medication. So when safe, you would taper the dose as appropriate for the underlying disease. So to treat caused by excessive, you would just give more steroids. No, you're going to taper them off. You're not going to give them more steroids. Okay? And tapering helps. You just always want to taper steroids that they've been on for a long time, so that you give the body time to make its own. Okay? Does that make sense, Lindsay? Or have I totally confused you? Kind of the opposite of Addison's. Addison's, the adrenal glands are being destroyed and they can't make cortisol. So you have to give them hydrocortisone in pill form. But Cushing's disease, they have too much corticosteroid, and it's usually due to giving them too many for whatever reason, for treatment of whatever disease is causing so much inflammation that you have to give them high doses of steroids. So you can try to prevent it by limiting the amount of steroids, and you can taper the steroid dose so that you don't throw them into Addison's. You will throw them into symptoms of Addison's disease if you've been on high doses of steroids for a long time and then you just cut them off, because their body their body hasn't had to make any hormones any of the cortisol for a while. So it's not making its own corticosteroids. So you have to taper the dose and let the body, get used to that biofeedback. The adrenals start to say, oh, well, there's not enough cortisol, let's make some more. Addison's, they can't do that because the adrenal glands have been destroyed. Okay, I'm sorry if I'm confusing you. If you didn't taper the patient appropriately, they would develop Cushing's. Okay. So for Cushing's, prevention is to try to avoid long-term high doses. Treat them as long as you need to, then taper the dose slowly so that their body picks up on its own. And then Addison's is due, again, to autoimmune destruction of the adrenals. So they're going to have replacement of corticosteroids for life. Okay. Lee asked, just for my knowledge, what would be considered a high-dose corticosteroid? I work in pulmonary, so we prescribe a lot of prednisone. I give 40 to 60 milligrams a day for short periods of time for asthma exacerbations in an adult. But, if you were given that every day for months and months, then you're going to cause adrenal suppression. because, you know, it's all a biofeedback, and the adrenal glands are going, well, I've got plenty of corticosteroids circulating. I don't need to produce any. So that's why you taper the dose when the patient's getting better. You taper the dose so that the adrenals will start picking back up and making the corticosteroids again. But you know, we give patients, you know, even higher doses of that if they're like admitted for status asthmaticus or other things. So I think it just depends on, I don't know that I can pick a dose, but I think it depends on the dose and how long it's given. You know, if it's given for more than a week and you're on a high dose, then you're going to cause some kind of suppression. 5 days of 60 milligrams of prednisone won't cause suppression. So I hope that answers it. Okay. Any other questions? Okay. So those are the main endocrine things besides diabetes that we're going to go over. So I know there's a lot of reading, but I'd concentrate on these. Okay. And like I said, next week we'll go over the diabetes case studies. So try to get the reading done before Monday for that, so that you can answer questions and get a little bit more out of the lecture by understanding what I'm talking about. Okay. Okay. Well, if I didn't answer your question, go ahead and post it in the forum, and I'll make sure I answer it then. Okay. Thank you very much.